All right, guys, good evening again, and welcome back. Sorry we missed a couple of the session last time, but we still have time. When is your exam? Next month or in November, December? When is the exam? The
The
written one.
final exam, still they did not specify the date.
Mm-hmm.
For
But
promotion,
usually
I
which
think
month?
usually January.
Oh, January.
Yeah.
Promotion in January
No,
after
no,
the
no. The
year
final.
end?
No, no, no. The final exam. The promotion
No,
usually
no,
in November.
November. Okay, so still have like 2 months to go. All right, that's good. How did you find the review course? Done by Dr. Isam. Was it good course review?
Yeah. It was a good course.
Okay, because we're planning to do it again, but in more professional way. PAVs will take over, and we try to do it in Amman in February. We'll let you know, guys. But if any feedback, guys, please send me on my WhatsApp any feedback about the course. If you like more subject or different subject or something missing to add it, I'm going to use one that I sum as a skeleton, but I'm going to do some changes in it. But I like to get some feedback because this is course mainly for you. So if you can give me some feedback, some subject to be more detailed, some subject is missing, you want to be different way, please give me your feedback so I can organize it and can get the best, course review. And then it should be like yearly, maybe twice a year we'll do it. And every time in different area. Okay?
Sure. Thank you.
You're welcome. All right, let's start. Bara, you want to start? Bara.
Yeah, sure.
Okay, go ahead, please.
So patient present with syncopal attack and acute left lower quadrant abdominal pain. He is resuscitated in the emergency department. A non-contrast CT scan is performed. He is hemodynamically stable and is taken to the hybrid operating room for endovascular repair. If the coil embolization is attempted,
Okay, so what does he have here? What do you see in the CAT scan?
that's probably an internal iliac, left internal iliac artery aneurysm.
Correct. So you want to comment how they treat it? How you treat internal iliac aneurysm endovascular? Like this one, how do you treat it?
You can do coil embolization for the two main branch of the internal iliac and
Okay.
blood for the main internal iliac if there is a suitable place for blood, and then cover the stent from common to external iliac artery.
Correct. What are you just putting cover stent is enough to put cover stent only?
No, you will have
No.
back bleeding.
Okay, that's great. So this is what you have to do. So they're telling you that you close the posterior division. We have two divisions. We have anterior and posterior, correct? For the
Yes.
internal iliac artery. Do you know where the posterior, where the anterior goes?
The
You
anterior
remember?
usually goes to the urinary bladder, to the genital organ.
صحيح. And the posterior go?
Posterior, it goes to the buttock, to the
Okay,
lumbar.
that's good. Right. So they want to know the name of the artery. So even if you don't know the name of the artery, as far as he said gluteal, then because it goes to the buttock, right? So even if you don't know the answer, but you can tell this is a gluteal because it's the only one has a, go to the gluteus muscle, correct?
Yes.
Okay, but then we can go through them. Obturator artery. So what do you think the answer?
No, I think it is the superior gluteal artery is the correct answer. Obturator artery goes through the obturator canal, but it is branched from the anterior branch.
Middle rectal artery. Again, I mean, even if you don't know it, the moment you see gluteal, name, this is the right one. Okay. Anyway, this anatomy is not a good question, just anatomy. Let's go take next one. It's nothing much in this one really. Let's take the next one. What is that?
Okay. Patient present to the clinic 1 month following successful endovascular repair of the left internal iliac artery aneurysm by embolization and diverting inflow with covered stent across the origin. He has a palpable distal pulses and no abdominal pain. The imaging study demonstrating thrombosis of the residual aneurysm sac. He notes that he has been suffering from mild cramping in his left buttock after he walked about 1 block. You advise him that the buttock reduction happens about 20% of patients after this procedure, and the time interval post-operatively in which typically resolve is. So this is a chronic buttock reduction. Usually it takes 6 months to improve.
Okay. Anyway, also this question, somebody may not know it because you didn't read about it. But again, in general, anything takes at least 6 months. I mean, this is like a default, you know. If somebody has claudication, they want to improve, you tell them it takes about 6 months. You know, if one patient have been after surgery and nerve damage, then it takes 6 months. So 6 months is very default. So if you don't know the answer, always go with the 6 months. I think you'll be on the safe side. Okay. Again, it's not a discussion question. So let's leave it. Let's go to the third one. Let's go to a good question, like a scenario. Why is no scenario? Let's try this one. Go ahead to this one.
Okay. A 62-year-old man is undergoing an open repair of an abdominal aortic aneurysm with concurrent aneurysmal degeneration of the right common iliac artery. After completing the proximal aortic anastomosis, the right common iliac artery aneurysm is opened and a short segment high-grade stenosis of the right internal iliac artery is observed 1 centimeter beyond its origin. The left internal iliac artery is occluded at its origin. To decrease the risk of pelvic ischemia, the best distal reconstructive technique should be.
Well, let's go through one by one and see if it's correct or not. Okay, let's go with A first.
Okay, distal anastomosis at the right iliac artery bifurcation. This is inappropriate.
Why?
Because you still have an stenosis at the internal iliac, around 1 cm distal to the bifurcation.
Correct. Especially the contralateral iliac is occluded. If it's not occluded, it's okay. You can do it. But because the contralateral iliac is occluded, then you have to be sure this internal iliac has good blood flow. So this does not address the internal iliac stenosis, so it's wrong. Okay, next.
Distal anastomosis at the right external iliac artery with ligation at the origin of the right internal iliac artery. No, this is also should not be done.
Correct, because you're not addressing the flow to the internal iliac artery. And second thing, we never do anastomosis to the external iliac artery, guys. We never. Either you go to the common iliac or you go to the common femoral. Do you know why? We never do external iliac artery anastomosis. Because external iliac artery, like an SFA, it's very bad artery. It's the worst artery. The worst two artery in your body is external iliac artery and SFA. They get disease, they get occlusions, so it's not good. So like we never do like SFA to popliteal, correct? Always we go to common femoral. So always external iliac like an SFA. We never take inflow or outflow from external iliac, you know. Always you like to go to common iliac. So when you do anastomosis, either you go to common iliac artery or common femoral artery. So this is also wrong. Next.
Ligation of the common iliac artery and distal anastomosis at the right common femoral artery. No, this doesn't address the problem of the internal iliac.
Correct.
Distal anastomosis at the right external iliac artery with additional graft to a healthy segment of internal iliac artery. This may be an option, but there are better options.
Okay.
And finally, endarterectomy of the right internal iliac artery with patch angioplasty and distal anastomosis to the graft, distal anastomosis of the graft at the right iliac bifurcation. This is also not a good option. I have another option, but it's not written there. I think it is better solution for this patient.
I mean, here, of course, if you want to become one, which one you become?
I will take option number D.
Correct. Even though I just said it's not a good option. But this is tell you how is that, I always tell you guys, books books is just an opinion of a writer. It is not like a Holy Quran. He said that doesn't mean he is right. I will never do anastomosis external iliac artery. If you want to do it, I'll do it to the common femoral artery and do an extension or additional graft to the healthy segment. But if you have to choose one of these, even though I will not do it. The problem with E, angioplasty anastomosis to the graft to the right common iliac, is a good one, but the problem is the anastomosis is 1 centimeter after the origin. So it's really deep in the pelvis. So doing endarterectomy with a patch could be really difficult, even though sometimes if the patient is very thin, it could be very feasible. But and the other option, you can go and put a stent if you want. Like, and you go there, put small stent, and then do anastomosis to the common iliac artery. What other option you want to mention it?
I would like to do distal anastomosis to the internal iliac, healthy segment of the internal iliac artery, and then attach the external iliac to the graft.
Say that again. Sorry, say that again.
I will do anastomosis end-to-end over a healthy segment in the internal iliac artery, and then reattach the external iliac over the graft. Like a sequential anastomosis.
No, don't do that. No, don't do that. It's your main concern is the legs, not the internal iliac. Internal iliac is okay, but it's not your main concern. The first concern is the legs, okay? So this is what you have. So graft has to go to the place where it's the best flow to the leg, not to the internal iliac. Internal iliac, yes, we have to preserve it. It's not your priority. So I will never do a bypass to the internal iliac artery and then take a graft from the internal. Second thing, don't do end-to-end anastomosis. This is the worst one. It's difficult technically. And the second thing is always a mismatch. Internal iliac is small, and you're going to put a bifurcated graft, which is about 8 millimeters or maybe 9, depending how aorta big. So it'd be difficult to do end-to-end anastomosis. So I don't think it's a good option. So either you do aorto, like common iliac or common femoral, and then you address the internal iliac. But first, you have to be sure to graft going to the legs. So your bypass should be at the iliac bifurcation or common femoral artery, and then you have to find a way to get blood flow to the internal. Either you can do a jumbo graft, you can go put a stent from inside, or you can do transposition. It's the easiest way, the best way to do transpositions. You just cut the internal, and you switch to the external iliac artery. This is the easiest way. But the problem here, the stenosis is 1 centimeter after the origin, so it's too far. So I think it's difficult to get the internal transposed to the external. So the question is not very clear. See, this kind of questions, it gets you confused in the exam. But in real life, in practical life, when all the case I did them, usually the origin where the stenosis or occlusion is the origin. So what usually we do, they aorto by iliac, and then you cut the internal and you hook and you transpose to the external iliac artery. This is the best option really. Any question about this question? If you want to do anastomosis the external, you start from the common. Then you can go to the external, but you never do the anastomosis completely to external. Like when you do the common femoral artery, you do anastomosis to the common femoral, you can extend the graft to the SFA if you want the first part, but we never put a graft on the SFA as an outflow. So the same external iliac artery. Try, guys, not to put a bypass to external iliac artery, either common femoral or common femoral or common iliac artery. But if you get in the exam question like that, you have no other options. Of course, you have to pick up what the most reasonable, which is D. Any questions? All right. Who's next? Faisal, you want to take next one?
Yes, sir.
Any question? Hello? Any?
You want
Sorry,
to read,
guys.
sir?
Yeah, please. Yeah, Faisal, yeah, please.
Yeah, okay. 32 years old.
Please,
man.
everyone mute his. Yeah, it's a lot of noise. Okay.
Unfortunately, the noise I have team.
Sorry, it's from you?
Yeah,
If you want, I can pick up somebody else if you are.
you
Yeah,
don't
it's too
mind,
much
sir.
noise.
Yeah, thank
Yeah.
you.
Who want Osama? You want to take it, Osama?
Yes, Dr. Samer.
Okay, let's take this question.
32-year-old man arrives in shock following motorcycle collision. Radiographic, sorry. Yes, shock following motorcycle collision. Radiographic evaluation reveals splenic laceration, a pelvic ring fracture. The CT angiogram shows blunt grade 3 aortic injury and semi-elective thoracic endovascular aortic repair is being planned. The utility of intra-procedure endovascular ultrasound IVUS in determining the proper endograft size for TVAR in young trauma patient can be explained by.
Okay.
He's
So he
asking
came
about
here.
the IVUS. Yes, the IVUS, the role of IVUS in measuring of aortic diameter.
Correct. But what the message here he want to tell you that patient when it comes with hypotension and you do a CAT scan, what the problem with sizing?
Sometimes it's to be inaccurate because the over-resuscitation sometimes for these patients in trauma.
Right, but when he come, he just hypotensive, you know.
Yes.
So usually is undersizing. So always when you do a CAT scan, initially when patient come, and especially in shock. So when he's shock, he's already hypotensive. So you get a smaller size of the aorta. So your measurement will be wrong, you know. So if you size aorta and initial CAT scan and you go to put a TVAR, then you'll be surprised that TVAR is small because we don't oversize much in the trauma. The reason why they prefer to do an IVUS or after resuscitation, you repeat a CAT scan. But it's difficult to repeat a CAT scan. So what happened when you try to do a TVAR, patient already resuscitated, most probably now is more stable. Then you do an IVUS to get an accurate measurement. Okay, let's start one by one.
Okay, initial CT angiography may oversize the aortic diameter. In hyperdynamic physiology, it is the opposite. This is undersize the aortic diameter. Yes,
correct.
Aortic elasticity and compliance are directly related to age. I don't think this is the right answer.
When we get old, no, just a second, Ahmed. When we get old, is aortic elasticity and compliance increase or decrease when we get old?
Elasticity decrease.
It become more stiff, right? So it's decreased.
Yes.
When we get old, the aorta become more stiff and the compliance become less. So when we get old, the aorta elasticity and compliance decrease. So here they said it's directly related to the age. It's the opposite. It's indirectly related to the age. It's the opposite because the more we get old, the aortic elasticity and compliance goes down. Correct?
Yes.
So this is the way you have just to know the answers, you know. So this is wrong because it should be indirectly. If the opposite would be correct, if they said aortic laxity and compliance is reversibly related to the age, they will be correct. All right, next one.
Next one, IVUS may account for the changes in aortic diameter during resuscitation. I think this is the one the right answer, but we'll see other one. The angiography is better than IVUS for measuring the aortic diameter. No, the IVUS the IVUS is better than the angiography.
Correct.
Variation in aortic diameter during the cardiac cycle is minor in hypovolemic shock. No, and such a patient hypovolemic shock will be underestimated the aortic size and diameter. So I think
they're talking about the correct. You see, they're talking about the cardiac cycle. Cardiac cycle based systolic and diastolic. And there is almost sometimes 30% change in the diameter of the aorta in the area, not the diameter, the area. The area of the aorta changed 30% between systolic and diastolic. It's the reason why when you do a CAT scan, you don't know if it's in systolic or diastolic. And this is the reason we always oversize because we don't know. And many times, if the CAT scan is not like rapid CAT scan, you see a haziness around the aorta because this cut happened where the aorta is between systolic and diastolic, you know. The reason why I always, when I measure the aorta, I take the outer diameters because I want to be sure I took it in the diastolic, you know, not in the systolic. So So the reason, so the aorta changed a lot between systolic and diastolic. As I said, some studies showed 30% change in the area of the aorta between systolic and diastolic, and major changes happen in the anterior wall, not the posterior wall. So if patient is hypotensive, then you see major change also in the cardiac cycle between systolic and diastolic. So all this will confuse you when you do your measurement, because CAT scan is not is a static, it's not dynamic. So when you make a cut, you don't know what's systolic or diastolic. So if you made a cut in the systolic, the diameter will be different than if you made a cut in diastolic, you know. The reason why in these situations, IVUS is the best way. But of course, this is not practical, because not everyone has an IVUS, and sometimes patients rupture, you have to do it quick. The reason why we like to oversize, you know, we oversize about 10%. So this way we are like more on the safe side. This is the main reason why we oversize in the trauma, because we want to overlap this change in the aortic diameters, you know.
Yes.
Or what you want to do, resuscitate the patient and repeat the CAT scan, even without contrast, just to get the real diameter of the aorta. If it was really hypotensive, if patient came with severe hypotensive when you do the CAT scan, it's better to repeat it without contrast when he's fully resuscitated. If it's minor hypotension, I don't think make a major difference.
Yes.
Any question?
To
No.
Samer, regarding the measurement from outer walls, there is a difference between the companies in
Yes.
drafts.
Yes, that's correct. So they tell you inner to inner, somebody outer to outers. I mean, at the end, it's your decision. See, company is a company, you know, they just tell you what you think. The reason why I do my own measurement, you know. But in general, you never go with oversizing. All problem come from undersizing, you know. So if you oversize, it's better than undersize, because undersize is a problem. You get a leak, you cannot fix it. Oversize, especially now with the new devices, are very flexible. You don't see infolding, unless if you oversize like 50, 60%. The old devices was very stiff. So if you increase too much oversize, you see infolding inside the device. But now the devices are very thin, very flexible. So even oversize is not a major issue. So always go more to the oversize than undersize. Okay.
Okay, thank you.
The only problem, and I always do that, I oversize even 20% instead of 15%. Oh, the only problem, see, nothing perfect in the world. The new study showed that the neck diameters, infrarenal aorta, it get dilated with the time. And one reason of dilatation over time is oversizing, more than 10% really. So now you're stuck. If you oversize, you get a better seal, but in the long run, you get more dilatation of the aorta, because oversize, it put a pressure, continuous pressure, because this is like, you know, stent. So oversize, it keep putting a high pressure on the aorta. So with the time the neck get dilated and device can move down. So this is what they showed, that the aorta, the neck diameter change related to the oversizing, and they recommend not to oversize more than 10 to 15%. This is a new study. Okay. So I used to do oversize even to 20. Now maybe I'll go back and maybe stuck between 15 to 20. You see, every time you have to change your practice, depend what the new paper, what the new study showed. You have to also be updated, you know. Go ahead.
Samer, do you oversize in traumatic TVAR for pediatric patient like 16 or 18-year-old?
15, 16, 18-year-olds. At first, it depends on what size you want to use. But no, we don't like to oversize much, you know. Always think about this problem, because if you oversize much, then you end with infold, you know. Like we don't go more than 15 to, I mean, like in trauma 10%, I may go to 15, but not more than that, you know. So no, we do not. We do not oversize.
Sometimes, Dr. Samer, you have patient who's traumatic aortic injury with the diameter around 15 or 16 centimeter.
Right. So what do
And
you
the
do in this
smallest stent we
situation?
have is 18 or 21. The smallest
Correct. So
aortic diameter. I will use the smallest one.
No, there's other option. Because let's say it's 14, and let's say it's 14. No, You have 14, right? And the smallest one is
Yes.
21. So it's too much oversize. 21 and 14 is too much. So what do? You do iliac. You do iliac limb. You do one of the limb. They have a short, small one in the limb. So try to use the iliac limb. Like they have 16, they have 20, you know. Gore, they have 18. Cooks, they have 18. So try to use iliac limb. This will work, you know. Doesn't have to be a thoracic aorta. You just need a cover stent. That's all. Is the whole idea. So you can use one of the iliac limb. Okay.
But if they grow up, is there any problem that may happen with this iliac limb?
Look. تعرف I'm on recording, so I cannot say that, you know. Yeah, this like the same idea, the old idea they used to say, if you don't have a good saphenous vein on the right leg and have to do distal bypass, they said don't go to the left leg because you may need it in the future, correct?
Yes.
This is the old teaching. They said if you have to do femdistal bypass to save the right leg and you don't have saphenous vein, don't go to the left leg because he may need it, correct? This is very old teaching. Now we have to use what the best vein for the bypass. So what I want to say, solve your issue problem now and leave future for the futures, you know. In the future, we'll find a problem. We'll find a solution. But don't complicate your problem now because you want the future, because for the futures. So you have to give him the best surgery now. Don't worry about the future. We can fix it later on. You know, when he grow up, if he has an issue, then we can fix it. You may do an open repair. You may find a different way. But don't complicate your case now because for the future, if he grow up, he may die before that. He may have car accident. He may die before he reach the adult. He may have other injury. He may not even make it through the the trauma. So don't think this way. Always think what the best solution for this patient at this moment. It's not only for the thoracic, even for the legs, for the bypass. Just always think what the best solution for now. Don't worry about the future. I mean, unless if you have an option, like when you do a coarctation, yes, and when you do coarctation with aorta, we think about it. But because we have an option, we use like a balloon expandable stent, and then we can dilate it with the time. But in trauma, you have no other option. You cannot use balloon expandable stent in trauma. So the only option is to use self-expandable, and you are limited with the sizing. Then use the right size now, and don't worry about the future. Okay? Any question? All right, let's move next. Who's available? Yasin, want to take it, Yasin?
Okay, inshallah. Salam alaikum.
Yeah, hala. Let me see what's this question. Here's question 15. Okay, go ahead.
A 24 years old helmeted motorcycle suffered high impact collision. He arrived hemodynamically stable with a normal neurologic examination. CT angiogram show aortic injury along with left pneumothorax, lung contusion, splenic laceration, and multiple rib fracture. The most appropriate management for the blunt aortic injury is
Okay, so we have 24 years old, high impact collision. He is stable, so that's good. No neurological exam, normal. Aortic injury, left pneumothorax, lung contusion, splenic laceration, multiple rib fracture. So what the best treatment for blunt aortic injury these days? Is open or TEVAR?
TEVAR.
TEVAR. So now everyone does TEVAR now. I mean, and also they showed that TEVAR less mortality than surgery. So TEVAR is your first choice of treatment, right? Okay, let's go through the questions. And this is grade what? This is grade 1, 2, or 3 here?
It's grade 1.
No, grade 1 just intima, but you see aneurysm here, right? See how's aneurysm here?
Yes.
You see that? You see aneurysm here? You see it?
Yes.
This is a grade 3. This is a grade 3. In general, grade 1 and grade 2 conservative. Grade 3 is semi-elective. Grade 4 with the free ruptures, it is an emergency. You have to do it immediately. The most controversy is 1 and 2, everyone agree that conservative. Number 4, everyone agree immediate TVAR. All controversy in grade 3. When should be done? Should we do it or not? It should be done, of course. Even some people, they try conservative, but the guidelines do not recommend it that. And I will not recommend it that for you guys. When you see grade 3, I think you should do a TVAR. The only controversy is the timing. Every place they get panic, even in our hospital here. This is what I was discussing with the guys today in our hospital. They got, like yesterday, a traumatic thoracic transection, and they jumped right away and did a TVAR. And after they finished TVAR, they found that the patient is already brain dead from the injury. So I told them you should not do immediately TVAR in type 3 transection if patient is stable, no hematoma. You can wait. And also they showed that even the guidelines said delay repair is better than immediate repair, especially if you delay 24 hours, you get a better outcome because you can have a time to resuscitate the patient, you have a time to fix another injury, and then you go fix the thoracic aorta. But this is only if patient stable and no periaortic hematoma. If you have periaortic hematoma, patient unstable, then you have to do it immediately. If patient has a brain injury, what the problem is the brain injury, the neurology, he want high blood pressure because he want to perfuse the brain. So if you have a head injury and the neurology want to elevate the blood pressure, then you have to do it immediately. But this is the only 3 scenario you have to do it immediately. Otherwise, always it's better to wait for 24 hours before you repair the thoracic transection for type 3. Okay?
Okay.
So let's say what they said here now. Let's go one by one.
No intervention is necessary. Recommended follow-up imaging in 1 week.
This is not
correct.
Yeah, because type 3, and I said we need to do it, but not like not no intervention. This is wrong. I'm saying you have to delay it, but it's not mean you don't have to do it. You still have to do it. But no intervention is wrong. Okay.
Repair at discretion of trauma team.
That
Not
means the trauma team will make a decision, which is wrong because we are the one because they are the one who make a decision, correct?
yes, correct.
Okay, so it's wrong.
Stabilization of concomitant injury, anti-impulse control, semi-elective repair. I agree with this one.
Okay.
Immediate repair.
Okay.
Patient is stable and no
Yeah.
neurological age.
No hematoma.
Yes. Semi-elective open repair of the blunt aortic injury. TVAR is better than open repair now.
Semi-elective open repair of TVAR is much better now. So the right answer would be C.
Yes.
Correct? Yeah. You see, this is also it is. Let me see what was the question. The most appropriate management of the blood injury. Of course, as I said, the guidelines they said C, but it doesn't mean that if you did immediate repair, you are wrong. You see, I mean, you can argue, well, I want to repair it now, But the only thing against it that the study showed that immediate repair has more mortality than if you delay 24 hours. So this is the only thing against it, immediate repair. So again, if patient is stable and no hematoma, I think it's better to wait more than 24 hours, just to give some time for the aorta to heal and resuscitate the patient. Immediate repair showed increased mortality rate. Okay?
Okay.
Any questions? No. We'll go to the next one. 27. Who is with us? Faisal still have a noise?
No, I'm here, sir.
No? Okay. Just go and take it.
Okay. A 27 years old woman involving in high-speed motor vehicle crash, suffering traumatic brain injury with intraparenchymal hemorrhage and underwent thoracic endovascular aortic repair TVAR for grade 3 blunt aortic injury the following morning. The left subclavian artery was partially covered. 6 months later, she presented with bilateral lower extremity weakness, numbness, and pain. Based on the CT angiograph finding showing in the figure, the most appropriate measurement is.
Okay.
So
Before we start, you see what they said? They said they did TVAR for grade 3 the following morning. So just try to emphasize that it's better to delay your treatment, you know. This is just a small note, you know. All right, the left subclavian is partially covered. So subclavian is still open. 6 months she came with a paralysis. What do you see in the CAT scan here? Let me see the picture if you can see it clearly. What do you see inside the stent?
it looks like there's thrombus inside the stent.
Yes, there's a thrombus and severe stenosis, right?
Yeah, yes, sir.
So she's getting a significant stenosis, like, you know, this is more than like maybe 60, 70%, you know.
Yes.
So this will decrease blood flow to the spine and to the legs. And this is the
Yeah.
reason why she get a paraplegia now, because she has no flow. It's almost an occluded aorta, you know. Correct?
Yes, so.
So we have to address the reason why we have a problem here. Okay, let's see what option he gave us.
Okay.
Okay, let's see. First one.
A, immediate systemic anticoagulant and CT angiograph surveillance. No, we will not go with surveillance because we have to act for
Correct,
this
because it's
situation.
symptomatic.
Yeah.
And paraplegia is almost paralysis. If you wait, it may go to paraplegia. So you have to act.
Yes, sir.
This is correct. Okay.
B, magnetic resonance imaging and neurological consultation. Also, now we already know that she had stenosis and there is thrombus. So this is the source of the problem, and we need to.
But Faisal, if you do the MRA and neurological consultation, it's not wrong, correct?
Yes, agree, totally agree. Yes, but
so why this one is wrong?
Because as I can see here, also the patient have thrombus inside the stent.
No,
so,
but when you answer, you have to answer only this sentence. Is this sentence correct? Forget about it. He's not talking about, like, let's go to first A. If he said immediate systemic anticoagulation,
he's correct.
And he stopped, this be correct, but this is wrong because he said CT angiogram surveillance. This is wrong, right?
Yes.
So if you say MRA imaging and neurological consultation, this is correct, you know? But why is wrong here? You see my point? If you take this sentence itself, it's not wrong. You can do MRA and neurological consultation. It's not bad, you know? This is just a part of the, you know, scenario. But it's wrong because look what he said. He said, what is the most appropriate, you know? Not what the management, the most appropriate. So this is not the most appropriate. It's one of the measures, but it's not the most appropriate. So you have to carefully read the question, you know, because he said what the most appropriate, it's not the most. Yes, it's appropriate. One of the measurements, it's not the most appropriate. Okay, the reason why it's wrong.
Yes.
Let's go to the C.
C, cerebrospinal fluid drainage, intensive care unit admission, and serial examination. We know that the patient, he had maybe a spinal ischemia, but in the same time, it will not be the definitive management for this patient.
Right. So the first part is correct. You do CSF drainage, get him to ICU, but serial examination, I don't like this part because it's being conservative. This is why it's wrong, because he wrote serial examination. Because serial examination mean you go conservative, and this is not conservative. When you have a spinal paralysis or paraplegia, you have to immediately act immediately. It's like a compartment syndrome. The more you delay, the chance of recovery is very low. So if he put it without the last sentence, also be correct. But because he put a serial examination, then this is wrong. Okay?
Yes.
Let's go to the next one.
The emergent angioplasty and distal extension of thoracic stent could be an option.
Right answer. Yes.
Yeah, right
Let's go to
answer.
the last one.
Angiography of the left subclavian artery and revascularization. No, it's not related at all.
No, it's not related, because if you have subclavian, it contribute to the spine perfusion, you know. If there's no stent, but I tell you what against this one, two things. First, they said is a partially covered subclavian, correct?
Correct.
So that
yes.
means you still have flow to subclavian. The second thing is that, but you tell me maybe it's got occluded, correct? Maybe it's occluded now. But you look
Yes.
at the images, he did not show me the subclavian, correct, in the images.
Yeah, true.
So I have to presume it's open, because if it's occluded, he has to show me. I cannot presume it's occluded, you know.
Sure.
So because he did not show me the subclavian, I have to presume it's open, especially he did partial coverage. So if it's already partially covers and already open, then subclavian revascularization will not help in the situation.
Yes.
Okay, so in this patient, really, the best way is to get them to ICU, get CSF drainage, intensive care unit, increase blood pressure, increase his hemoglobin oxygenation, you know, to be sure he's sat more than 95%, hemoglobin more than 10, CSF drainage, and you take him emergency for restenting. Okay.
Yes.
MRA is not helpful, really, wasting of time. MRA is just wasting of time, because you know from clinical he had a spinal ischemia. So MRA will not add anything. So I will not do it. Anticoagulant, I will not start it, because you have to do CSF drainage. Unless after you put CSF drainage, then you do it. But you don't do it immediately. You don't do immediate systemic anticoagulation, because you want to do CSF drainage. So you do CSF drainage, then you put on anticoagulant. So this patient, if he come to you, CSF drainage, ICU, increased blood pressure, be sure his hemoglobin is good, saturation is fine, systemic anticoagulations, and then take him for angioplasty and distal stent.
But I have a question here regarding this.
Yes, please. Yes.
Thank you, sir. Regarding this stenosis and thrombus inside the stent, what is the most likely etiology that can cause this situation for this patient?
It's really, I see that. I saw maybe one or two cases. He got embolization. They form stent because a reaction to the stent. Some people's reaction like any stent. They get intima hyperplasia and they got thrombus. It's not very common, but it happens. I never saw was something like that. But one time I know Bara was with us. I remember a patient, young patient, he has the same traumatic and with the TVAR, and he came with the lower embolization to lower extremity. And we did an echo, everything looks normal. And we did embolectomy. He did fine, but anticoagulant. And then he come after a month with, again, 3 months with embolized lower extremities, severe ischemia. We do embolectomy. We change anticoagulant. He said, maybe it's not working. We did an echo. We do everything. It's nothing negative. Then he goes here. Then he came 3rd time. Also embolization again. You know, and again, we look at the heart. We look at everything. Looks fine. We do embolectomy. We change his anticoagulant. He said maybe he's resistant to agratropan. Maybe he's resistant to heparin. We change it with warfarin. He came again with the embolization. And he's a young guy. Finally, we look at the CAT scan. I found that there's some thrombus at the wall of the stent. So I think that what is happening with this guy is that thrombus forming at the wall of the stent and then dislodge and go distally. So I went there and I put stent inside the stent, you know. And since that time, he stopped embolization. So it happened. It's very rare. This is the first case I see it with like that. But keep it back in your mind, could happen.
Okay.
Okay. And when you put a stent, of course, you put it longer than before. So you be sure that, because if you put exactly the same size, the blood can move and go down. So just be sure that you really extend it at least like 3-4 centimeters beyond the first stent. So be sure that all the clot being trapped inside the stent. And you don't do balloon first. You put a stent and then you do ballooning. So you be sure that all the stent will be trapped on the side when you're ballooning. If you balloon ahead of time before, then you may end with embolization. Okay. And this clot, they don't respond to thrombolysis because they're all chronic clot, you know. So either you have to do an open thrombectomy if they embolize, or you have to do a mechanical thrombectomy.
Okay.
Was that question?
No, it's okay. Clear. Thank you.
Assalamu
Okay.
alaikum. I have a question, Dr. Samer, if you allow me, sir.
Yes, please.
Two questions, actually. First question, you already answered it just now. Spinal cord drainage and therapeutic anticoagulant might be enough for such cases, or I need to intervene by angioplasty, mechanical thrombectomy, I mean.
No, we're not doing mechanical thrombectomy here. We're only, in this case, we're just putting a stent inside, and then we do gentle ballooning just to open it. No, I think this patient, he need intervention because he had severe stenosis. If he just was only a clot, on the side, but you don't have stenosis, then you may go conservative, as you said. But because he has severe stenosis, I think he need to be treated.
So clearly. My second question, please. Putting covered stent distally will not make the spinal cord ischemia worse, especially in this patient situation?
No, because you just go 2-3 centimeters, doesn't make a difference really, 3-4 centimeters. Because as I said, if you put exactly at the same area and then you balloon it, then this clot will squeeze and go down. So if the new stent is not after or beyond the first stent, it may embolize, So at least you have to go 2-3 centimeters, like a space, maybe 2 centimeters just distal, just be sure. And don't balloon proximal because you don't want to squeeze a clot to the carotid, So you have to be very careful. Most probably I just balloon distal with the stenosis. I will not balloon proximal, You have to be careful with these cases,
Thank you, sir. Clear.
Okay. Who Abdullah here. Abdullah, you want to take next question, Abdullah?
Sure.
Yalla, please, Abdullah.
A 72-year-old man with a history of a chronic obstructive pulmonary disease, hypertension, and smoking presents with a 6.7 centimeter type 4 thoracoabdominal aneurysm. He is seen by his pulmonologist, who deems him a high risk for open surgery. Which of the following statements is true regarding the endovascular repair of his thoracoabdominal aortic aneurysm?
Okay. Let's talk about fever and beaver, right?
Yes.
All right. So let's go one by one. Most of it is like information here, but let's go one by one.
Okay. Approximately 15% of the patient will require secondary intervention on their renal arteries. Seems reasonable.
In the exam, you may not know this number, but you can tell if it's too high or too low.
Exactly. Yeah. Seems reasonable number, actually. It's
15%. 15, a little bit high, on the high side, 15. Most studies is about 6 to 7% for the renal. And for the celiac and the SMA, maybe like 1 or 2%. So 15 a bit on the high side. Yeah. Okay.
Second option, patients suffering from spinal cord ischemia are most frequently treated with perioperative steroids. This is seems
like when
part of the intervention, yes. But it's not the right answer.
Right, because when you have thoracoabdominal aortic aneurysm and patient has spinal cord ischemia, what do you do first?
Exactly, drainage. This is the first.
What do you do?
Yes.
Okay. Steroid, usually steroid really brain more than spine. I rarely give steroid for the brains. We give steroid. Spine, for some reason, we never use a steroid. Or you can use it as an adjuvant, but it's not the most frequent. Not the most frequent treatment. The most frequent treatment is the CSF drainage.
Yes.
Okay.
See, there's no difference in a branch vessel's outcomes between juxtarenal and thoracoabdominal aneurysms treated with fenestrated endovascular aortic aneurysm repair (FEVAR) versus branched endovascular aneurysm repair (PVAR).
Okay. Well, let's talk about, before you answer. Let's talk about PVAR and FEVAR. What's the difference between both? When you decide to go with FEVAR and PVAR, all depend on anatomy, because PVAR is easier, but you need a wide aneurysm, wide aorta, so you can get the branches open, you can go through them. Unless you use an inner branch, is a new one. But most of the one in the market done outer branches. Whereas a FEVAR, if you have aorta is narrow, and then you have the, you have to have fenestration close to the orifice. So as you see, the difference is anatomical more than functional. Functionality, really, both are exactly the same. So decide between beaver and fever depend on anatomy, nothing to do with the patency. Both are the same patency, everything the same. Complications the same, patency of the branch the same. So this is correct because no different in the branch between both. A decision to go either one depends completely on anatomical anatomy of the aneurysm. Okay.
D, there is a higher risk of stroke with the use of upper extremity accesses. Doesn't seem logic.
It makes sense. But I'll tell you what the problem with this one, that also they showed is not. And the reason why most of the time we use left arm really, and left arms away from the carotid, you know.
Exactly.
But also they showed there's no difference really between upper and lower extremities.
Lower
So this
extremity.
is wrong. Yeah.
The 30-day mortality of either fenestrated or branched EVAR exceeds 10%.
It's not very high.
It's less, yeah, this is very high.
It's about 7%.
Yes.
You see. So the best answer is C.
C, yes.
Yeah, the C answer is no different. So again, I mean, intervention again, just to summarize it, usually renal is about 6%, iliac, SMA and celiac is about 2-3%. If you get paraplegia, the first thing to do is CSF drainage. Fever and fever patency is the same. Stroke is no different for you upper and lower extremities, unless you use the right hand in excessive more often, then you may have problems. But most of the time we go from the left extremities. Mortality for fever, of course, is less than 10%. Yeah. Any question? No. Okay. Who's that? Well, let's get somebody. Iman. Who's Iman? Are you with us, Iman? No. Anybody else want to volunteer to pick up a question?
I can read again, sir.
Okay, go ahead.
Okay, a 48-year-old male vegetarian presented to the emergency department with tearing of chest and back pain. He had history of hyperlipidemia and family history of coronary artery disease. He is identified to have an aortic dissection that originates in the ascending aorta and extend into the common iliac artery on the right. He undergo an emergency ascending aortic repair with hemiarch. Postoperatively, he developed worsening renal function and abdominal pain with lactate 7.6 millimole per liter. The aorta just distal to the left subclavian artery has true lumen, false lumen diameter about 38 millimeter. Which of the following statement true regarding the aortic dissection? So in general,
first, go ahead.
Yes. So in general, this patient have a history of ascending type A aortic dissection, which been treated in hemiarch repair. He developed abdominal and renal vein, and looks like he had the false lumen about 38 millimeter. But it doesn't mention that it's thrombosed or it's patent. No. And he want to ask what is the true regarding the aortic dissection.
So do you think this patient need to be treated or not? Is the first question. Do you think this patient need to be treated or not?
He had lactate is high actually, so I think he developed hyperperfusion symptoms. Maybe
Okay.
yeah. So he need to be treated.
Okay. So this like now it's almost like type B because they fix the ascending, correct?
Yes, sir.
And now we like type B dissection, and this is a symptomatic type B dissection, correct?
Yes.
So it has to be treated. They put 38 to confuse you because if it's asymptomatic, we wait until it become 40 millimeters, you know?
Yes.
So if they do not say the symptoms, they just say 38 is not a threshold to treat it. Treated should be 40. But the moment they said abdominal pain and lactic acid is high, this is really indicates for emergency intervene because he's getting a bowel ischemia now, correct?
Yes.
So this is, so you have to interfere. It's not another choice, okay?
Sure. So
Okay.
A, using
So
the
let's
new,
run. Yeah.
using the new
Go.
SVS STS reporting standards, the patient should be classified as type B. Okay.
7. Let's go 3, 4. First, do you know what SVC STC reporting standard? If you don't know it, you need to read it, guys. It's now is a new reporting for type A and B, and so it's more accurate for reporting. So at least you have to study before the exam because we make it questions. It has 3 numbers. First is the A or P. The second number, which is where the tear start, and second number where the dissection end. Okay. So this patient, he came with type A dissection, correct?
Yes.
So it's not type B. This is the first wrong. Yes, now we consider type B, but he came as classification, he came with type A. And the second thing, the starting 0. 0 is the ascending aorta. So it has to be type A. You cannot have B 0. B should be 1 and above because 0 is ascending aorta, correct? So it has to be
Yes.
type. So if you put a 0, it has to be A. You cannot have B 0.
Yes.
If you have to be, it has to be 1, 2, or 3, or 4, whatever, but it has to be not 0. 1 arch, they consider type B. So if you have after is from the arch, then you consider B1 or B2, depending what zone. Okay, and the last number is where the dissection end. It's the level of the renal, SMA, and all they have to look at the numbers, you know. So this one is wrong because the first thing is B is wrong and 0 is wrong. So this is 0 is correct, but the B is wrong because it's 0. It started the ascending, but it should be type A07, not B07. Okay.
Is the paper of I think there is one paper also, the European guideline. They take this classification at the same time also and apply it. The new guideline, I think European, is 2 years back.
Yeah, it's really more for statistics. It's very confusing to use it as in practical life. I mean, practical life of care is A and B and where's the extension. But this is good to compare study for research for something like that. I think it's good classification. But in real life, I don't use it. We still use A and B, and that's it, you know.
Yes, sir.
And now the arch, they called non-A, non-B. This is the arch, you know. This is the new classification. They call non-A, non-B, which is arch. But we still treat the arch as type B.
Okay. B,
okay.
the patient should have initially had an elephant trunk with thoracic endovascular aortic repair of the descending aorta. No, they already fixed the arch.
No, but they said they should have initially had an elephant trunk with thoracic endovascular TEVAR in the descending aorta. This is a perfect repair. This is the best repair. But remember, when patient come to emergency, they want to get him off the table alive. So when patient, the same like when you do a rupture, when patient comes with a rupture inferior aortic aneurysm, even if the iliac is dilated, you don't do aorto by fem or aorto by iliac. You do just tubergraft because when patient comes with emergency, your job is to get the patient off the table, not to do a perfect surgery. If you do a perfect surgery, you end with the patient dead on the table. So when you get patient in emergency, it's different from elective. So when patient comes with an emergency, your job is what in your mind, how I can get this patient off the table alive as soon as possible with reasonable repair, not with a perfect repair. So all patients come with rupture aneurysms, infrarenal aneurysm, 99% I just put tubergraft. I don't care about the iliac. Even if the iliac stenosis, if the iliac dilated, even illicit, of course, aneurysm is different. But like 14, 16, calcified stenosis, it's not the time to fix it. Get the patient off the table, always we can come back and fix it with the endovascular. And the same here, when patient comes with type A dissection, if you talk to the cardiac surgeon, They just want to get him off the table. It's not the time to do total arch and deep hypothermia and frozen elephant trunk and TVAR. This is a perfect scenario, but it's not the time when emergency. So he said the patient should have, no, this is wrong, not should have. If he said the patient may be better treated with this one, then would be correct answer. If he said the patient better if he treated with elephant trunk and thoracic endovascular TVAR, then the answer would be correct. But he said the patient should have initially treated, no, it should not. As the initial treatment, just get him off the table alive, do the minimum, just fix the ascending, and always we have a way to fix it. As I said before to Bara, fix the problem now, don't worry about the future. Always we can fix it in the future. In the emergency, get the patient off the table alive as fast as possible.
Yes.
Okay, next one.
Okay, next. See, the hemi arch repair is preferred over frozen elephant trunk in this setting.
Hemi arch is preferred over frozen elephant. No, frozen trunk is better.
Yeah.
You know what frozen trunk, you know? So this is what I'm saying.
Yes.
This is in general, nothing about this case. I'm talking in general. If you talk in general, no, frozen elephant trunk is better than hemi arch, you know? Because this way you repair the arch, you already have a frozen elephant trunk, you can do TVAR, your life become easier. But this is in an elective setting, not in an emergency setting.
Yes. The
Okay.
treatment of the dissection is contraindicated with recent type A repair. No, I don't think so.
No, because patient now has symptoms, so you have to treat him.
Yeah.
So if patient you did type A and develop a symptoms, still the distal lumen is not open, then you have to treat it. It's not complicated. You have to treat it. So even has a type A, it has type A, but if you still have a problem, you have to fix it. Like the same, let's patient came with abdominal pain and malperfusion to the bowel. And you do a TVAR. And after TVAR, still malperfusion to the bowel. It should not stop. It should continue, right?
Yes.
Until you solve that. The same here. Even if you did, so you do the ascending aorta. If patient symptom resolve, it's okay, fine. But if you still have a symptoms, then you have to go to the next step, which is you have to do a TVAR, okay? So in this case, you do a TVAR and you look. If it's still bowel not getting enough, then you have to put uncover stent, the Cook bare metal stent. If it's still not enough, then you may have to go do fenestration. If it's still not enough, you may have to put stent in the celiac or SMA. So this is the step we do it. You know, always you start proximal, we go distal. But at the end, we have to get perfusion to the bowel. Bowel is the most important. If patient get a dead bowel, he's dead. Okay?
Yeah.
Patient when it comes type A dissection and bowel ischemia, this is the only place where you do the bowel ischemia first before ascending aorta. If he came with elective ischemia, it's not an issue. You do the ascending first. Bowel is different because dead bowel is dead patient. So if patient came with a bowel ischemia and ascending at type A dissection, and he has a bowel ischemia, you have to treat bowel ischemia first before you do the dissection. Because if you wait until the dissection repair, which take about 6, 7, 8 hours, the bowel will be dead. The bowel dead, patient is dead. So the only place you do interfere before repair emergently type A dissection is the bowel ischemia. Renal is not a problem, renal, because nobody will die from the renals, you know. Even if he end with the renal failure, you can put on dialysis. But dead bowel is dead patient. But if he came with the leg, even dead leg is not a problem. You can do amputation. So you see, legs, renal doesn't take priority on type A dissection. Bowel is the only one take priority because again, dead bowel is dead patient, but dead leg, dead renal is not deadly.
Yes.
Okay. All right.
Yeah.
Let's go next. Last one.
Last one. The patient should undergo TVAR. Yeah, I agree.
Yes, this is the best. Yes, but it could be not enough. You see, yes, you do TVAR, then you have to evaluate the patient. I mean, inside the OR, after you do a TVAR, you do an angiogram. You see if the flow going to the bowel or not. If you still the flow is not enough because the distal lumen still collapsed, then you have to put uncover stent. Okay.
Yes.
If it's still not uncover stent, it's not enough, then you do fenestration. If it's not enough, then you go and put stent for the SMA. So this is the step you go one by one. All right. Are you tired, guys, or you want to continue? It's 38. you want to do more questions or is enough?
We can go with a couple of 2 questions.
Okay, let's finish to 20. Okay, let's go 2 more questions. See, not this one, not this one. 19. Okay. We had a volunteer.
I will take this question to Samer.
Okay, go ahead, please.
A 67-year-old man presents with acute onset of chest and back pain that he describes as a tearing pain. He's promptly diagnosed with an acute type B dissection with the entry just distal to the left subclavian artery and termination of the dissection in the infrarenal aorta. Which of the following is true?
So it's not a scenario, it's just more questions, you know. So I'll just tell you that the symptoms, what's the most symptoms. So we can go very quick over it.
Okay, chest pain is the most common presenting symptoms of type B dissection.
I mean, they come with a chest pain, but it's the most chest pain mainly the most common. It's not that common, the most common. You know. So in most common type B is a back pain. Type A is chest pain, but you can have them both. I mean, you can come chest pain with a type B dissection, but not the most common. The most common type B is back pain and chest pain for type A.
Yes.
Okay.
B, mortality rates are higher in patients with lower extremity pulse deficit. Don't think the mortality will be changed with the. I think the mortality will be higher in patients with low perfusion, like bowel ischemia, renal ischemia, and
Right.
other.
Right. And he said just pulse deficit. He didn't say like ischemia because he may have pulse deficit and still have good collateral, correct?
Yes.
So the question is not, he didn't say like lower extremity ischemia, he said pulse deficit. But you can have no pulse still like still alive, right? It has good collateral, you never know. So this is not right, you know. Yeah.
CT angiography is the most common imaging modality for the diagnosis of type B dissection.
Yeah.
The most
That's what
common,
we do,
yes.
right? We always order it.
Yes.
This is what we order all the time. The CAT scan, right? It's the most appropriate for type D dissection.
Yes.
Correct.
The
Okay.
DNA aneurysm degeneration occur in approximately 10% of the patient with acute type B dissection.
You mean
I think it's the percentage is more. I think it's almost 20 or.
It's more really. And this is the reason why most people now, even uncomplicated type B dissection, treated with a stent, because they argue that about 40-50% they will end with aneurysm in the future. So let's fix them now. So the number is really high. Even if you don't know, the number is not 10%. I think it should be like about 40%. So it's really high. Correct.
Yes.
Okay.
Mortality
Next
rates are
one.
higher. Last one. Mortality rates are higher in patients treated surgically versus those managed medically.
This is kind of question.
Yes, mortality will be higher in patient, but such a patient, is it symptomatic? Is it?
I'm saying that saying it's bad question. I'm saying this is some people write questions, very bad question. If you talk about asymptomatic, no, of course, medical is less mortality than surgical.
Yes.
If you talk about symptomatic, of course, surgical is less mortality than medical, because if he's symptomatic and you do medical management, he will die, correct? Or ruptures. So he doesn't tell you. So, but the answer should be C, right? But this is tell you how is a bad, question. It's a bad question, really, because he should say more specific,
Yes.
Yeah. Okay. Let's do the last question, 20. So we get at least 10 questions. Oh, it's a quick question also, I think. Want to do it also, Ahmed? You already did.
Okay, I'll do it. A 6-year-old farmer presented extremities with abdominal pain, hypotension, and back pain. On arrival to the hospital, his blood pressure is 65/32, and bedside ultrasound confirms 6.8 centimeter abdominal aortic aneurysm. Which of the following is true? This patient is presented with signs of symptoms of ruptured AAA.
Correct.
Yes, which of the following is true? Overall mortality rate for ruptured abdominal aortic aneurysm is around 50%. No, it is more than that, a lot.
How high you think?
Yes. B, the
Go, go.
incidence
What do you think? What the number? You think what number you can give it to them?
ruptured, I think it's 80 to 90%.
Yeah, that's really high. Yeah.
Yes. The incidence of
Correct.
rupture AAA has increased in the last 40 years. I'm not sure about the
No, we
sentence.
don't. No, because we're doing more EVAR now, right? We do, you know, so we treat more patients now because it's easier to treat them now. We do a lot of surveillance now. We are more active now, right? Than 4 years ago. Now you do a surveillance program, everyone looking, because treatment is easy now. We are more like, you know, aggressive treating AAA. So the instance is instance of rupture is less. Yeah, it's decreasing.
Yes.
Yeah.
The improvement in endovascular technique have not influenced the mortality rate of rupture AAA. No, this is wrong. Completely wrong.
Yeah.
It's,
So it decrease the mortality, right?
Yeah.
It decrease the mortality rate.
Yes. The rapid and aggressive resuscitation and preparation for the repair of rupture AAA improve survival rate. No. So one of part of the management is permissive hypertension and do not go for aggressive resuscitation to avoid more rupture and causing more
Correct.
damage to it.
Correct.
So
Okay.
smoking cessation is the most effective non-surgical intervention to reduce risk of aneurysm-related death. By exclusion should be this E, the right answer.
Right. Yeah. No, there's some studies showed that smoking, you know, it increase the risk of rupture and aneurysm. But smoking cessation, I'm not sure because damage already happened. You see my point? That's the risk of aneurysm-related death or rupture. Let me see. Death, not ruptures. Because smoking cessation will not decrease the incidence of ruptures. Look at this way. Look at this way. You have to smoking increase the risk of rupture and aneurysm. Okay.
Yes.
But stop smoking will not decrease our chance of ruptures. If you stop the smoking, the risk of rupture is still the same. Okay. But the risk of death, I don't think is affected. It's the most effective surgical intervention to use. I don't think there is a risk of death, you know, because this is not related to the smoking, you know, related to other things. So this would be wrong. So the right answer will be what we said. No, this will be, sorry. I said that stop smoking will decrease the risk of death, but not the ruptures. So the right answer will be E.
Yes.
Yeah. So it decrease the incidence of deaths, aneurysm deaths, but not the aneurysm ruptures. Okay.
Yes.
All right. You want to continue? No, enough today with time. Oh, it's 46. Okay, I think it's enough for today. Any question before we leave?
يعطيك العافية.
Thank you.
And even out of this one, anything else, guys? Any questions you want to answer?
يعطيك العافية دكتور سامر، شكرا لوقتك، الله يجزاك
طيب
خير.
خلاص، يلا بالتوفيق يا شباب، يلا سلام.
شكرا جزيلا دكتور.
Thank you.
العافية.
سلام.
جزاك الله خير.
نعم. في أمان الله.
سلام.